Welcome everyone. I wish first to thank all of you who came in person today and those who have joined us online. In particular, I want to acknowledge that this lecture is co-sponsored. We have sponsored by CASPER, that is our campus center to advance chronic pain research. It's co-sponsored by the Placebo Beyond Opinion Center at School of Nursing. And we are delighted to have our member from the Society for Interdisciplinary Placebo Studies across countries, as well as the member of the International Association for Study of Pain. And thank you, Renee, for beginning with us facilitating this collaboration. I would like to introduce my friend and colleague, Laura Simmons. So Professor Simmons is a very well-known scientist who has research related to pain in pediatric population. Before beginning at the Department of Anesthesiology, Perioperative and Pain Medicine at Stanford University, Laura spent substantial time in Boston, where she was working at the Children's Hospital Harvard Medical School. Research is extremely innovative and interesting, spanning from brain imaging to therapeutic digitals to improve pain outcomes in adolescents and in children. So I'm very delighted to welcome Laura to this lecture. Thank you very much.
Thrilled to be here. Let me know if you can't hear me well, but I think I'm pretty good at being loud. There's so many things I can talk about today and so many different lectures. So I will, spoiler alert, I'm not going to be talking about any of the brain imaging work today. I decided to focus on sort of some of the innovative approaches to treatment of chronic pain in young people in today's lecture. But maybe you can come back and talk about some of the other work that we did. Okay, I don't think I need to tell this audience about the scope of chronic pain, but many people don't recognize that young people often have chronic pain. When I tell people that I study chronic pain, that I treat young people with chronic pain, I often get the question, I didn't know kids had chronic pain. Well, in fact, a quarter of young people live with chronic pain. And when it comes to musculoskeletal pain, those numbers are even higher. And often what we're seeing now is there's studies that are being done looking at those young people and transitioning into young adulthood, and they continue to have chronic pain at 2/3 the rate, and sometimes even higher, particularly again in musculoskeletal pain. So this is not just an issue in childhood, but it's an issue of sort of that progression into adulthood and those adult pain patients that we see. And some interesting sidebars is we also see that mothers with chronic pain, approximately 50% of them have children with chronic pain. We're still not really understanding all of those aspects to understand the social aspects, the genetic aspects, those other pieces. But it's very common for adults who are presenting with chronic pain to have family members in their household who also have. So it's really a family affair as well. So this also may not be news to this crowd, that pain is both a sensory and emotional experience. This is actually a slide from one of the classes that we do called Empowered Relief for Youth that I'll talk about a little bit later. But this is often not talked about with our youth. And often they will even say that the sensory aspect, the unpleasant or the intensity of the pain has been central, but that emotional experience has been so far neglected. And this is actually an example of that. So we've been doing a qualitative study for the last few years in relation to a biomarker discovery study, and we've interviewed 50 young people and their parents, and kind of looking at their pain care journey, trying to understand kind of their engagement in pain care, what team members are involved, how they define recovery. There's a number of research questions that we have. But at the beginning of each interview, we asked them to draw their journey. So when did the pain start? What was going on? And tell us a little bit about that journey. Well, as you can imagine, what they actually depict really varies across these young people. But this is an example of one young person who 1 year later, we tracked these patients for 1 year, 1 year later was still really struggling with pain. And they wrote in their journey, I think the emotional component is very undertreated. Everybody focuses on the aspects of the pain that you can. Well, some of us might say, even mine, is that we're probably not even really doing a great job of treating the sensory aspects of pain. But really, this sort of depicts sort of that complex journey. This is another young person's journey, where you can see a little bit of more of a hopeful picture. This is, how they engage with care. They're sort of running the mile, they get injured, they need crutches, they're getting sort of those initial tests, and then they are, they go into physical therapy, they go to the pain clinic, and then their foot gets better and they're playing soccer again. This was kind of more of a uplifting story. And here's another one where we see some hope at the end of a very long journey. So, this is not uncommon for our young people to be kind of engaging with multiple providers, getting transferred to different care settings before finally sort of developing a treatment plan and beginning that journey of hope and recovery. So I've always been really interested in trying to figure out what treatment is best for what individuals, sort of this precision medicine idea. And back in 2011, which is quite a while now, I was at the European Pain Congress, and I heard folks giving a talk about the Start Back tool, which is a screening tool used in primary care for chronic low back pain in adults. And I thought, this is really cool. They have this brief 9-item tool that they use to put people into low, medium, and high risk categories. And then based on that, they were using that to allocate level of care, some way to sort of kind of make sure that the people who are kind of struggling the most get the highest level of treatment earliest, and those who are probably less complex can get kind of a more streamlined treatment approach. So we actually worked with Jonathan Hill, the author of the Start Back tool, to develop one in pediatrics. And this is the pediatric screening tool. And we've validated in headache, and we've actually collaborated with some folks at Oregon Health Sciences to develop a parent screening tool, because parents also struggle in the context of their child's pain. And so we put forth a few years ago the idea of what it would look like to actually use the screening tool and mapping different levels of care based on sort of screening tool like the PPST. So you can see here, starting out with some pain science education as sort of as a fundamental basis. And then adding and layering in different treatment modalities based on level of risk. And I'm going to be talking about lots of these different treatments today, and some of the things that we're sort of working on, like virtual reality for individuals with chronic pain, as well as exposure-based treatments for individuals who have high fear. So pain science education. This has been kind of, it's funny that we know that this is kind of fundamental to, good pain care, but it's kind of surprising how kind of infrequent it's actually being delivered. And so I don't know if you all are familiar with Lorimer Mosley. That's the guy over here from Australia. He developed this beautiful video, Tame the Beast. I'm going to show it to you real quick if you haven't seen it, because I think it's just a beautiful way to introduce patients to.
Once upon a time, all the lands were fraught with persistent pain. So widespread was this affliction that 1 in 4 people experienced it. The pain lasted for more than 3 months. It shadowed their daily lives, held them back from everyday activities, and the interventions they tried proved.
The assignments would come and it would be like midnight the night before, and like, I need the poster board, Mom. Like, where can we get the poster board so that I can, do my assignment that I had avoided for so long? It felt in the short term like a great relief, but in the long term led to a very distressing late night dash. And then we work on what we call character development. So we use this tool called Pagoda, Photograph of Daily Activities. We've adapted it for young people, but there's also one for adults. And we have them look at a number of activities kind of activities of daily living, sports, other functional physical activities, social activities, and we have them rate on these kind of pictures. And this can be really helpful for young people when they really struggle with like, I don't know what I want to get back to. I don't know like what I'm not doing. I'm just not doing anything. And that can be really hard to sort of build a roadmap for kind of where to take treatment when they're kind of feeling really stuck. This is an example of one young person's ladder where they were kind of a busy body. So we actually had the pieces of paper that we wrote out and stuck them on here. And what's really interesting is up at the top of the ladder, so the things that were most difficult, cheerleading, gymnastics, that makes sense. It's pretty physically intensive, but it was also like mom not being home. So like equally scary in relation to her pain was like mom not being by her side, you know, when her pain might get worse or something like that. So these can be really surprising too, and aren't necessarily just like what's the most physically challenging aspect to face. So over the course of our development of this intervention, when we first started, we would ask young people when they were starting to engage in an activity, okay, what's your worry level on a scale from 0 to 10? Because a lot of this was borrowed from like anxiety literature and how anxiety treatment was run. And what we found was that people really had difficulty disentangling the worry number and their pain number. So even after they had kind of successfully engaged in the activity, they might not kind of report less worry or distress. So we had kind of our meeting with the PTs, OTs, and psychology, and we said, okay, what's a different way to shift the way that we look at success in doing these activities? And we came up with the Wellness scale. And this is, so we have young people rate before they start an activity and after the activity, how willing they are to do it, how important it is to them. And we say like, well, if it's not at all important, maybe this isn't like the thing to do because you're not going to be incredibly motivated to do something that doesn't feel important. And then people will say, but what about if it's like doing something related to school? Maybe the kid doesn't think that's very important, but the parent does. And it's like, well, we probably need to like discuss that and work through that a little bit before bringing it to the sporting activity. And then it's like degree of how likely they feel that they will be successful and how to do this. And this is where we're able to develop this sort of expectancy violation where real learning occurs. So they're able to see like, this is how bad I thought it would be. And then after they did it, they're like, oh, actually, and this can be just a really wonderful teaching moment for them that they can take with them to kind of any future activity, they can go wild. So in the context of this, we also talk about an exposure action plan. So what are ways that we can sort of have them continue through an activity that feels really hard? So we talk about activity facilitators. My favorite is listening to music. So, you know, running through the streets of Baltimore this morning, you will guarantee that I had my AirPods in my ears and I was like listening to my favorite song. Because if I was just listening to me breathing, I wouldn't get very far. So that is what I consider a very robust activity facilitator, listening to good music that makes you feel motivated and positive. Taking movement breaks, using deep breathing, and then the standard, you know, coping statements. So how have outcomes been for this? We did a single case experimental design trial in Boston. And for those of you who are not familiar with this trial design, it's absolutely brilliant and I highly recommend it, especially if you're trialing a new intervention in a small sample. And essentially what you do is you have a randomized baseline period. So in this study, we had anywhere between 10 and 21 days where we were collecting daily diary measurements. And then you have kind of your baseline, and then you have start of treatment, and the start of exposure, of course, that pick who shows that beautiful red avoidance go down and down and down, of course, of the intervention. But these are actually the plot lines of all of the young people that were in the intervention, and using like linear modeling thing that this wonderful Lisa Deckler did the work on, that allowed us to sort of plot the individual lines. But you could see that this was highly effective in this context. And something that was important to note is that, like real life, this intervention, we continued until the patient was showing signs of improvement. So in many clinical trials, right, and I'll talk about clinical trial that we've done since, you have a set kind of number of sessions or a set interval so that you're able to compare your two treatment arms. Well, the beauty of a single case experimental design is that you can actually use the response to be your marker of when you end treatment. So in the course of this, we had young people, we actually had one patient who did one exposure session and they got it. And then they were like better. And that was brilliant. And then we had another patient that needed 9 exposure sessions and was still like maybe not all the way there, but it was like, okay, we have to let them graduate. So there was a lot of variety. We had, I think the average was 6 exposure sessions, but we did have a lot of variability in the number of sessions that which is more like real life. So since in relation to this, we did, this will work, we did some motion capture analysis, looking at gait mechanics as it relates to the trial. We looked at clinically meaningful change. We saw that at 3 months follow-up, we saw 70% of the young people in the trial show clinically meaningful and significant change, which is really wonderful. We looked at sort of longitudinal narratives of the parents, which was really neat to actually kind of track almost in a quantitative way their qualitative kind of experiences in the course of the treatment. And then we did our randomized clinical trial. And you all may remember, there was like this thing that happened in 2020 that changed everything. And we were in the midst of our trial. And one thing that was kind of cool is that our clinic was already doing a little bit of telehealth. So we were actually able to transition this trial to virtual within a week. So all the patients that were actively enrolled were transitioned to virtual care. And you can see here, lovely psychologists, physiotherapists, and the patient doing their intervention. One of the really kind of cool features was that then the patients were doing some of their exposures at home, facilitated by their therapist. So you can see this young person hanging a birdhouse at her home. That would not really be possible in a PBO gym. And what we also saw, another kind of benefit from that phase, is we saw the ability to reach individuals go up dramatically. So our recruitment rate of individuals who were able to commit to enroll in the trial went from 44% to almost 71%. And so I'm going to briefly share the outcomes from this RCT. I think it was very interesting. So one, we didn't see a difference between the multidisciplinary pain management and our Get Living intervention. And I should describe what our multidisciplinary pain management was. It was 6 sessions of physiotherapy, 6 sessions of CBT for chronic pain, and it was done in that same frequency of twice a week. It was really good treatment. So I think in some ways it was wonderful to see that there were no differences. We also didn't see like huge improvements. And I have a couple of theories on that. One is that this was in the midst of the pandemic. And we just completed some analyses that I don't have here, but we did see, as soon as the pandemic hit, we also started administering a measure to look at exposure to different ways that it had impacted the family and kind of and based on that, we saw attenuated responses among those who were most impacted by it. So I think we have some of that going on, as well as kind of what we did in our early trial, where we treated them more like real life, where you treat them until they're better, versus like treat them until the end of the trial and then you say, thanks for participating, you're done. But we'll see that you're still not as good as you could be. So lots to learn from the different ways that we do our trials and how we can do them better in the future. I'm excited to say my colleague Lauren Harrison has developed a digital version of this intervention that she's just completed the pilot trial for. It's called I Get Living. And it's just kind of a beautiful translation of the content and the ability to kind of do it in these kind of micro learning sessions over the course of 6 weeks. And I'm excited to see kind of what the outcomes are. And let's see this video to give you a little bit of a preview of this digital intervention. Oh.
Hi there. Welcome to I Get Living, an internet-based graded exposure treatment for chronic pain. I am one of your team members who will be supporting you on your journey. We are happy you are with us. The reason you are here is because you have pain that makes it hard for you to do things you want to do. It is also likely that a lot of effort has been made by you and your family to reduce or get rid of your pain. Let me tell you about this program and what you can expect during your time with us. The first several modules will focus on learning about chronic pain, as well as all of the skills you will be using throughout the program. I know your pain is what brought you here, but we will focus less on reducing your pain and more on helping you get back to the activities that have been disrupted by your pain. This may seem counterintuitive, but bear with me. After the first week, we will be working together to set goals that are personal and important to you, which you will work to accomplish during your time in this program. We will also be working together to get you back doing the activities you want to do while taking time to acknowledge and reflect on the effect your pain has had on your life. You will practice setting goals that are realistic and attainable for you, and you will learn how to break tasks down into smaller, more achievable steps while you work to reach a larger goal. We will practice these skills together so that you can have long-term success, which means gaining mastery over these skills and integrating them into your everyday life. Other patients who went through a similar treatment program shared advice, including:
stick with it and keep on going. Try each activity even if you don't want to. Give it a try.
It is so nice to have self-reflection. Before this, I didn't pay much attention to myself. Now, I can see how I can best help myself.
and
I was scared to do much of anything. Now I got moving and I can see a difference.
the program is made up of short, daily modules that contain information and activities to help you learn about pain and create an achievable plan to get you back to the activities you enjoy. Each module should take about 10 minutes to complete. We ask that you log in and work on a module each day. Working a little each day will help you create new, lasting habits. I know life can be busy, so we will send you automatic reminders each day to log in. It will take you about 6 weeks to complete the program. You will also be able to send and receive messages with your treatment team via the messaging function, and our team will be able to provide feedback to you on the exercises you complete. Feel free to send us a message when you have a question or need extra support. It's normal to feel overwhelmed when starting something new like this program, and your treatment team is available to provide guidance when things feel tough. We are really looking.
Okay. So in thinking about the next phase of the in-person trial, we also have really kind of leaned into doing more co-design methods. So we have what we call the Better Panel, and that is bringing everyone together to elevate research. So it's a panel of families and patients with lived experience who they meet on a quarterly basis, and we consult with them about different phases of treatments, intervention studies, research studies. We may say like, hey, we're recruiting for this new thing. Like, these are the flyers we're doing. Like, do you feel like this speaks to you? Like, how do we need to change it? Like, in ways, and at this point, now we have patients with lived experience involved in all of our grant applications. Many of our manuscripts, or we have co-authored individuals with lived experience. It's really kind of made everything better by getting their expertise on how we can do better with the research, do better with kind of disseminating and getting kind of the work that we're doing, rather than that 17-year lag between when we do the research and when it gets out into the community. We're kind of trying to make that instantaneous. So it's been really powerful. So we did these co-design meetings a couple of years ago to help us sort of solidify what the patients kind of told us that were key treatment processes, as well as ways we can improve the intervention. And what are the things that we have to preserve as part of it. And so we got some really beautiful feedback from them regarding, having flexible delivery, wanting booster sessions, wanting to hear about these interventions sooner. Like one of the big things was like, why didn't I know about this sooner? Like I didn't hear about this until after I was in a tertiary pain clinic and I've been living with pain for at least 2 years. Like, aren't there ways that I could find out about these types of interventions earlier? So we can definitely do better in those spaces. Those were some of the themes that came out from that work. And this is our goal. I was telling Luana I'm working on a grant revision, and this is it. So this is the Get Smart trial that we're hoping to be able to execute. It involves 6 different institutions, actually including Kennedy Krieger. And we are looking at again, sort of going back to this idea of that if you give them the right dose and use their response as an indication of when you proceed or abort treatment, that's really going to lead to the best outcome. So this uses the SMART trial, which is an adaptive design trial that allows us to do multiple moments of randomization so that we are getting patients the right level of care over the course of their treatment. So hopefully I'll be, able to report on the outcomes of this in a few years. Okay, so I'm going to shift gears a little bit and talk about some of the other fun interventions that we've been up to. We've just wrapped this intervention called pain rehabilitation virtual reality. So this was kind of initially based on work that we had done in our intensive pain program at Stanford, where they had developed a particular game called Fruity Feet that, oftentimes people will say is that, there's a lot of VR games that engage the upper body, but there's not really much that engages the lower body. And for young people, most of the pain that they experience is often in the lower extremities. They're more likely to have lower extremity injuries that persist. So they developed Fruity Feet that allows you to put those devices on the feet with the sensors, and then they're stomping fruit, and there's slingshot aspect there. It's super fun. The kids really dig it. And so we did an initial kind of co-development trial in the rehab program and saw some really great signals. So then we, and then another video.
Wow, nice cake. Oh, that's orange.
Okay, so this inspired us to run a trial where we wanted to actually put kind of this sort of VR enhanced physical therapy into outpatient spaces. So we had a very ambitious vision. And I think one of the things that's important is not everything is goes perfectly as you envision it to go. There are often times when things don't go as great, and we actually have a paper on it that is essentially about all the challenges we had in this trial. So, if you want to, not just hear the good news, but also the struggles, because that's where the most learning happens, is not in success, but in failure. You know, we wanted to disseminate that so other people could learn from the things that went wrong for us. But one thing that we did is we really wanted to get into spaces where it's not just tertiary pain care. So we were reaching out to outpatient PT clinics, but there were a lot of logistical challenges to having VR facilitated PT in those outpatient clinics, and even within our own rehab program. You know, therapists would struggle with like, well, do I look like I'm not doing as much because I have my kid in a headset rather than like working with them? Like they were concerned about looking not totally competent using the VR equipment if there was an issue that came up, like casting, being able to actually see what the patient is seeing. There's often technical glitches that can happen. So they didn't want to lose credibility in front of the patients by having some of those things happen. So it's like we really kind of leaped into real life, and a lot of kind of challenges showed up. We've just finished this trial, so I don't have any of those initial outcomes, but something else that we did is rather than just testing one game, we had the Fruity Feed that I mentioned before, but we also used some other games that were off the shelf, like Fruit Ninja, Beat Saber, and then another one that our Stanford team developed called Space Burgers that uses a little pedal bike. So you can have just like that pedal bike that goes on the floor. So the more they pedal, the more success they have in the game. So another way to engage the lower extremities. We didn't want to, like I said, we didn't want to test it to be kind of only dependent on one particular VR modality. So this is kind of like how we outlined a session to go. I can tell you there was a lot of variability in how this happened. And it often ended up being a situation where the patients were doing a lot of the VR at home. One thing that was really cool is that we worked with this Manage XR software that allowed us to see exactly when the patients were using the headsets and what games they were using and for how long. So we have a ton of data that we're sifting through. We have this brilliant undergrad who's been working with us and wants to develop VR kind of environments. And she's been working with all of this like usage data and breaking it down for us, which is not as simple as it looks like in the pie chart, for sure. But we're really excited to be able to dig into that a little bit and kind of see behind the curtain regarding kind of how people are really using the VR headset when they're being given it. And we do get positive feedback, so we can start there on the acceptability standpoint. People do really like it and they find it to be a great distraction and incentivizes them to do the exercise. So I think it's a lot of promise there. I mentioned at the beginning that slide about the pain experience. We've been doing a little over a year ago, we adapted the Empowered Relief class that's for adults, for young people. So this is a class that was developed by Beth Darnell at Stanford. It's been delivered to probably 20,000 adults at this point across the world. It's kind of mind-boggling. And certification as an instructor is one of the things that I find to be really cool is that it's not just for psychologists, nurses, PTs, OTs, MDs, any provider that is a licensed clinician, pharmacist, could be licensed to deliver Empowered Relief, which it's a 2-hour workshop that can be delivered online or in person. And it has these sort of fundamental components that I'll talk about. So one of the things that we did when we developed the Empowered Relief for Youth is we shifted a lot of the graphics. We made them kind of more young people friendly. I mean, who doesn't like a dog with cucumbers? And the goals. So it goes back to the pain science education that we talked about earlier, how pain is processed in the brain. We show pictures of the brain. You know, families, kids, they all love the brain pictures. I apologize, I don't have any brain pictures for you guys today. But I found it, you know, it's one of these things where it feels so validating when pain is invisible. Pain is poorly understood. Patients often feel, marginalized, stigmatized, invalidated, disbelieved, like in those pain journeys that I mentioned before. Time and time again, you hear young people say, like, I thought maybe I was faking it. I thought maybe my pain wasn't real because they had heard the message so much that they were internalizing that stigma that they had heard. So when you show them pictures of brain changes in relation to pain experience, it's validating to them. There's something that's like happening that someone can take a picture of that shows that my pain is real. So that's really incorporated into this and is really powerful. And then we also show them how they can change these areas of their brain by doing these interventions, these psychology interventions, and changing their mindset about pain can impact their brain. So that's also an uplifting message that the brain is plastic. And then the simple skills that then translate into a personalized plan. So, you can read all those clearly. I zoomed in on a few, but this is, because we were doing this, we had, when we first developed it, we got feedback from, individuals with lived experience, and then we did exit interviews. And over the course of the exit interviews, we were iterating. So we would get feedback and then we'd incorporate it and change the class in real time. We're still even making changes. Like, I feel like, I know that, gold standard, having things set and manualized and RCT is like, gold standard. But I think that we also need to be realistic about getting the best treatments. And that means sometimes being flexible and being willing to change things up a little bit to get sort of optimal outcomes for these patients. So initially when we did this, we didn't have breakout rooms, but the patients really wanted that opportunity to sort of connect with another patient. So we added those and they really liked them. And they liked what we were about. So another intervention that I want to briefly talk about is called flexible attention sensory training, our FAST trial. And this tool is called Train Pain. This was actually a tool that was developed for adults with chronic pain, but I mean, who's not gonna like a little baby squeal and like a bubble popping game? So they've never done it with kids, and we saw it, we're like, I think kids might like that. I mean, adults too, but one of the individuals that developed it was involved with developing Candy Crush, so it has some of that kind of aspects of it visually. So we did a trial that we just wrapped up and we're like writing up the results now. But patients were doing it for 15 minutes a day over the course of, I think we actually did 8 weeks, even though that's I think we actually did 8 weeks with 1 month follow-up. So looking at acceptability, feasibility, and kind of initial markers of outcome. And the idea is that there are these 2 pods that individuals can put, like we'll say, on the shoulders, and they vibrate. And they have, so it provides kind of tactile stimulation. And then what the individuals are doing is kind of shifting their attention to focus on the sensory discrimination path. So it allows them based on the vibrating pods, that's how you play the game. And so your success in the game is based on being able to detect where the vibration is coming from. So it takes in the sensory aspect, it's training their attention to shift. And sort of the fundamental mechanism is that if you're able to shift your attention towards and away from pain, to have that more flexible attention, you're going to be more successful in managing your pain. Because what pain, as we know, demands attention, right? We're hardwired to be drawn towards paying attention to our pain signals. So if we can actually train our attention to move towards and away from that stimulus, then the idea is that you will be more successful. And some of our qualitative data says that might be occurring. Patients are reporting being able to focus more, being able to kind of shift their attention more, able to engage in more activities, which is kind of interesting given that it's like a little thing that they do 15 minutes a day. And they love it. So I'll tell you, one, we had no problem recruiting for this study, which is not common. And we had like 100% completion on all of our assessment measures. Patients were doing it almost every day. We had really high kind of adherence to these 15 minutes a day. They actually wanted to do it more, but I think that's part of it, is that you kind of limit it so they can't like burn out on it. And consistency rather than like dosage in short bouts. But it's been really interesting and fun to have something that patients are really excited to do. So this is a little bit of what I showed. They loved the little baby seal, and like it also, you get like points and you can buy outfits for the baby seal. We had one patient that bought all the outfits and was like, I need more outfits for my baby seal. But never know. Again, we use that same method to try to get some feedback from patients, and I'm not gonna say that this is kind of like a cure-all. Like, I think one of the things that I find to be really important is that it's not gonna be that VR is the thing that kind of gets all the patients with pain better, or train pain, or get living, but we need really a suite of interventions depending on the level of care. So for individuals who kind of this sensory discrimination aspects, or the ability to kind of focus and concentrate is particularly important, this might be a fun tool for them to use to try to enhance their attentional flexibility. So where do we go from here? I kind of gave away a little bit of this. The big thing is that we want to apply this individual lens for patient-centered care. And that means really understanding all of these different aspects of the patient in front of us to understand kind of what might be the best treatments. So something like the Empowered Relief for Youth, we've now embedded that into our clinical pathways, so that we kind of want everyone who comes to our clinic to do that 90-minute class. It's online, it's super easy, we offer it free of charge, so there's no insurance barriers. And then after they've done that, then we say, okay, if you need kind of more pain psychology, we can do that, or other things. But it just sort of provides that groundwork. And we've heard from the providers that those who've done the class and then go to pain psychology are like more ready. They're more open. They're kind of like into it, which is also really great and kind of accelerates the ability of individuals to benefit from the interventions, rather than spending several weeks trying to get them on the same page with the treatment plan. Yeah, so so I think we have the opportunity to leverage all this like data that we're collecting, whether it's in registries, whether it's like in wearables. We have a study that we've just launched that's using Apple Watches in young people with chronic pains, so ages 14 to 24, and tracking kind of their daily experience to see if we can come up with a way to kind of chart their pain experience day to day using the sort of technology and data that's all there. I mean, I imagine in this room, many people are wearing smartwatches that are collecting their heart rate in real time, or some sort of activity monitor. So being able to leverage that information so that when they go to their providers and the provider says, like, how are you doing today? It doesn't have to be about how they're doing in that moment, but actually, let me show you my data. This is what the last month has looked like. These are, I've had several days where I, had a pain flare, and, then I had some other days that I was doing better, and like actually being able to use that data to be more efficient in kind of how we assess it allocate is the vision. So I've already said all of these things, so I don't need to do them again. Tribute to my amazing team. Jewel White is a recent graduate. She's gonna be here next week for her ceremony, her quitting ceremony. I'm so sad that the timing didn't work out, but she's a new postdoc in our group and she's been amazing. So keep them coming, Luana. Thank you. And that's it. Thank you.
Amazing talk. Thank you very much, Laura. So probably we can give time to those people online, because we can stay around, Laura, and address any questions after we prioritize those people who are online. Do we have any questions in the chat?
So I think Dr. Kleckner, yeah, she's he just raised it.
Hi, can you hear me?
Yes.
What a wonderful talk. Thank you so much for sharing that. So inspiring, and I love the way you think about things. I'm curious, You spent a lot of time talking about helping people pay attention to their sensations in their bodies and things like that and their pain. I'm wondering, do you ever, and I think that's all wonderful, but I'm also curious, do you ever see situations where people would benefit from paying less attention to their pain, to their body sensations? Just love to hear your comments on that.
Yeah, I mean, that's a really interesting question. I think back to my early days when I was like a psychologist in our rehab program. I'd be like, don't talk about pain. Like, don't talk about it, don't ask about it, don't. And it's like, don't think about a pink elephant. It's like, when you try to avoid, I mean, everyone's probably imagining a pink elephant right now, right? That's how it works. And so I think that, in some ways, it's changing the relationship to that awareness. So right now, there's probably a little bit of a, catastrophic interpretation of those sensations, or a kind of heightened worry of those sensations. That's sort of an added layer to paying attention. But there's actually been some interesting work in the kind of interoception realm that you may be familiar with. But that, that patients are actually don't have great body awareness. Like pain patients, like even though they've been hypervigilant about their pain, they actually lack good body awareness. So maybe by attending more accurately to the sensations, they actually will be able to interpret them in a more benign manner. So I think there needs to be kind of two things, like enhancing accuracy. And Lauren Heathcote at King's College London has just launched this huge trial that's going to be looking at interoceptive accuracy using this like heartbeat tap. That's really cool. It'll be interesting to see where that goes. And then how you interpret those, like at the cognitive level. I hope that answers your question.
That's great. Thank you. I've also talked with Lauren Heathcote a few times because we're both interested in interoception and cancer. So I was happy to see her picture there. I think the work you're doing is great. Thanks for the answer.
Thank you.
Questions in the room?
Yeah. So I wonder if there is any report that when during this childhood, a child start to have formed the pain memory, means what stage?
Sorry, say that again.
What stage means postnatal or gestation, means he start to have like pain memory, like he feels and he make a memory like, yeah, this type of pain I was having. Like just make it simpler, like during giving the injections. Like if the kids see the injections, he afraid, yeah, this is pain.
So, like when does a young person perceive the pain, or when does the memory of pain?
Yeah, pain memory.
Pain memory.
Yeah.
Well, pain memories can start in premature infants, like in the nervous system, right? It's encoded in the nervous system as early as those heel lances happening in the NICU. And it's just a matter of like whether you're talking about the nervous system remembering the pain, or like the individual being able to tell you about their memory.
I mean, maybe they don't have word to explain, but on what stage she started to have like memorized?
It's from the beginning, right? There's been some really interesting studies that have been done looking at kind of neonatal painful procedure exposure and how that rewires the nervous system and can impact kind of the trajectory of being more vulnerable to pain over the lifespan. And you've got to remember it was like in the 70s and 80s, we didn't even think that babies felt pain and we didn't give them anesthetics. So it's like really scary that it's not that long ago that we didn't even recognize that pain was happening. But yeah, from the start.
Thanks for the talk, that's great. I guess somewhat related to Ian's question, did you find that when it's like putting the participants through VR therapy, did they respond differently to like a VR program that isn't focusing on where their pain region is? So like if they had lower pain extremities, and they were playing Beat Saber, did they have a different response to if they were doing the fruit slash?
Fruity Beat?
Fruity Beat, yeah.
Yeah. Oh, we don't know that. That's a great question. Yeah, we don't know how, like, whether it needs to be like on the nose to
Yeah.
be helpful, right?
Yeah. It looked like she was still standing up while she was doing it.
Totally.
But it wasn't like,
Yeah, I think it's probably both. Always both, right? But I think there's so much that can be done with the virtual reality interventions that we're just sort of scratching the surface and like there's just so much to think about in how you approach it and how you measure the impact, right? So we even have measures in there that we haven't looked at yet, but like things like how fun that's been used. And I know you talked about like fall or something, right? Yeah.
But
Yeah, that I think can be really powerful. But isn't in our like core outcome in general, but we're working on that for
yeah. There's another question online. Interested in the attention shift aspect, if what gets your attention is magnified in importance and without avoiding talking about pain at all. I don't know if it's a question or they're trying to.
Okay. Oh, yes. Okay, so maybe in thinking about the trained pain intervention is maybe what they're talking about, and that it's non-painful, like, you know, vibration, that it's like a sensory, they're paying attention to something that's non-painful. And without sort of having to talk about pain explicitly, right? I think that's maybe what they're getting at. So I think that it's framed within, because one thing I didn't mention is that there's also like little insights that the patients get over the course of the trial as they kind of increase in levels, insights unlock. And there is sort of some education that ties those together, that like shifting your attention, learning how to shift your attention can be applied to pain. So I don't know if that, so we do kind of, I guess, talk about.
I had two questions. So I guess starting with, so there's been some research that indicates that the type of treatment that someone receives after an acute injury or like a surgery or something can have a big impact on if pain becomes like chronic going forward. Have you done any assessment of like the kinds of treatment that happened immediately after the pain? And have you seen any sort of a impact on outcome or like how long it takes for them to resolve their pain?
That's brilliant. No, there hasn't been enough research looking at kind of how, like, are there differences? Like, because not everyone who has like the acute injury ends up with chronic pain, right? We know that a lot of those folks resolve, their pain resolves. And so does their treatment course look different? I mean, these are like the magic questions of like, why do some people develop chronic pain? Why some people don't? And what hasn't been looked at is like the early interventions and how those might actually have an impact on those trajectories. I think that's important. And something like the screening tool could be done early. Because I mean, this is something like I tried, you know, I shouldn't give up, but after we developed that tool, I was working with a sports medicine doc that I was like, I'd love for you to use this. You know, you see a lot of orthopedic injuries, you see a lot of people, like, would you like just give this out and then we can see like how people do. And they're like, pain is like, we don't see that much. So it just like, they were just like, it's not worth our time, you know? And so I could see the same thing in a pediatrician's office, like, but I feel like we shouldn't give up at trying to screen early and understand from the get-go, like, are there, like, because if people because the thing is, like, there are gonna be people that are showing signs of risk already, like, for example, disrupted sleep. We know that that's like a risk factor for like everything. And if people are showing signs of disrupted sleep very early in their course, my guess is that that's probably gonna make them more vulnerable to persistent.
So my second question is a completely different topic. So you mentioned that there's like the psychosocial element of this like treatment framework. So you might not be able to answer this yet, but have you seen any changes or shifts in your results post-COVID shutdown? Especially considering that that changed the social life of a lot of children who ended up having online school and whatnot.
Yeah, that's a great question, and I don't fully know the answer. I think it's probably gonna, my sense from the clinical landscape is that kids are doing worse in general. And we haven't gotten back to where they're doing better. You know, so the kids that we see in our clinic look worse than they did pre-COVID. Like there's more complexity, there's more impairment, there's, you know, so I think across the board, everyone's doing worse. Maybe it's not just the kids. But so I do think that, I mean, kind of talking about this attenuation, like are all our treatments gonna look like not as good? Who knows? Like, hopefully, but I do think that we're dealing with a lot more complexity, comorbidity, and challenges in that way. Like even just the social aspects are really big. Like kids are kind of struggling with the social aspects in so many, like stunted, I guess.
Well, for sake of time, I invite those who want to ask a question to stay around. That's our another
One question. So the person who asked the previous question on attention shift, they were cut off. So I'll read the whole question. If what gets your attention is magnified in importance and without avoiding talking about pain at all, briefly, they're asking how central is attention shift? Is it solicited or spontaneous?
How important is attention shift? I think I'm struggling to understand the question entirely.
So it's like it's written and easy.
Um,
So in general, they're just asking like how, like, is it something that's solicited or is it something spontaneous?
oh,
Yeah.
well, like in the train pain, it is elicited, right? Like the sensory, the stimuli is kind of drawing their attention, right? Because it's giving the sensory, the sympathetic feedback that they're paying attention to. In order to be successful in the game, they need to know, okay, was it left or is it right? And like, so their attention is being directed in these different ways, so it's not. Hopefully I answered.
Great. So with this, we close the live lecture. Thank you very much for beginning with us. Look forward to meet you next. Have a nice summer.